So when we talk about adrenal, like many other endocrine organs, we talk about dual origin of adrenals as well. So if we talk about pituitary, we say adenohypophysis and neurohypophysis. So one is from a glandular origin and the other is from a neural origin. When you talk about thyroid, we have got the follicular cells and the parafollicular cells. Again, glandular versus a sort of a neurological origin. Pancreas, we have got the exocrine endocrine gland, which is there. When we talk about adrenals, we have got also two distinct zones. Of course, we have got the medulla in between and the cortex, which is outside. And this medulla is largely a neuroendocrine cells. So they are going to produce catecholamines, which are going to regulate the stress response in blood pressure. And then we have got the cortex region, which has got three specific regions. The zona glomerulosa, which produces aldosterone, regulating the salt axis. Zona fasciculata regulating the cortisol, controlling the blood pressure and water homeostasis, and finally zona reticularis, which is regulating DHEAS production, regulating a number of things like androgen effects, memory, quality of life. So when we talk about these three regions in the cortex, what is the difference in these cells?
They originate from same cells.
Yes.
There's a difference of electron activity of enzymes at different layers.
So it's not that they are distinct cells. Cortex and medulla, of course, are completely different type of cells. But cortex actually will have different zones depending upon how the cells pass to different zone, the environment changes. So the expression of gene changes, and you said very nicely, the availability of the number of electron changes, and that determines which way our pathway will go forward. So from a embryological perspective, the glomerulosa, fasciculata, and reticularis are not distinct cells. It is where you are there, you behave like. So if as we say that one is known by the company one keeps. So the cells which company they go, they start behaving like a fasciculata, reticularis, or granulosa from that perspective. So now if you look at development, I talked about that, of course, as many other glands, there's a dual origin of adrenal. You have got the glandular portion and the neural portion, which is there. And these portions will then develop into a embryonic adrenal. Then you have the mature adrenal with cortex and medulla outside. What is the benefit of cortex being outside of the medulla?
Because sir, the blood supply is centripetal, sir.
Okay,
so whenever there is high demand or the stressful conditions,
yes,
the blood supply will be increased, which will take more cortisol towards the medulla, sir. So there will be more production of epinephrine, sir.
Yes. So what does cortisol do? You just have to tell the last point. You've said everything clearly. So what does cortisol do to epinephrine?
Sir, it will activate the PNMT.
Very good. So
enzyme.
it activates the production of epinephrine. So in stress states, that's why cortisol is a major regulator of epinephrine production. So therefore, if you are cortisol deficient, now many people will ask, what is the role of cortisol in blood pressure? There is not much in terms of direct effect, but it also is essential for the epinephrine response. So if you have a low cortisol, not only your other mechanisms like cardiovascular action are there, but you also have a blunted epinephrine response. So when you talk about hypoglycemia, now if I talk about a different mechanism, we always say that there are four hormones which are going to save you: growth hormone, cortisol, epinephrine, and glucagon. So if your cortisol is low, your epinephrine is also knocked out. You need to remember that. And then if you have MPHD with growth hormone, you don't have only glucagon, which also fails after some time. So this is something to remember from that perspective. So we have got the cortex, which produces the cortisol, aldosterone and DHEAS, and medulla, which produces the catecholamine, which we discussed about that. We'll be discussing about individual synthesis subsequently as we are talking about these individual conditions. Now, adrenal is a very small gland, and as I just showed, it was only 4 gram in that perspective. So overall, for the entire size, adrenal is a very, very small gland. But that's not true. When we talk about fetal development, we'll say that the fetal adrenal is big. So if you say gram per kilogram body weight, fetal adrenal may be around 20 times more as compared to an adult adrenal. So when you have a newborn, the adrenals are huge. So therefore, if somebody says that there is no adrenal on imaging, you should consider that this is actually absent. Which glands are large at birth compared to the adult group? So one, we talked about the adrenal. Which other gland? Which should be picked up on the ultrasound? So one is related to thyroid. Thyroid is quite big at birth. and which not really gland, which structure is influenced by mother's hormones? Uterus. So uterus will be pretty big. They should be able to identify. So adrenal, uterus, and thyroid are big at birth. You should be able to identify that. Now, genetic regulation, we all know that we have got a urogenital ridge, which has got three major structures which are coming from there: the kidney, the gonads, and the adrenal. So they have got a common structure. Around 4 weeks of gestation, these are the primitive ones. We know hedgehog, we all talk about sonic hedgehog in many scenarios. WNT is also there for ovarian development subsequently. So all these enzymes are there. At 6 weeks, you have got separation into a adrenogonadal region, which involves multiple genes. The most important of them would be WT1, which we all know about. The gonadal development plays a major role there, and the kidneys. So from the urogenital ridge, automatically you have got adrenogonads separate and the kidneys become separate earlier. So if you talk about problems, often you find adrenogonadal problem more commonly, but of course kidney problems can also happen because of WT1 in that perspective. Around 8 weeks, you have got a primitive adrenal, which is formed, which is adrenal primordium, and a major gene which is regulating here is DAX1. Now, DAX1 or NROB1 is a very interesting gene. It has got multiple effects, which include, Dr. Alapan.
DAX1 is a antagonistic to SF1 in our type A1.
Yes.
It helps in the HDL transport in the adrenal.
It helps in the adrenal transport or counters. NR5A1 is helping. So this is antagonizing that. Okay.
Also
then
has an effect on pituitary, gonads, and adrenals.
Yeah.
So
it is opposing the growth of testis. It is promoting the growth of adrenal, and it also is having an effect as far as the GnRH, the area, the gonadotropin area in that perspective. So if you have a DAX1 defect, typically you will have adrenal hypoplasia congenita. So your adrenals will become very small. You will have hypogonadotropic hypogonadism. Testosterone biosynthesis and cortisol biosynthesis is also defective. So these are the scenarios. Would it also cause DSD? A DAX1 deletion or a defect?
no, it will not cause DSD in deletion, but
Yes.
it can cause if it is excess.
So we need to be very clear about this. Often people get confused because it's involved in gonadal development, adrenal development, pituitary development. The DAX1 adrenal phenotype is not the one with DSD. It will be associated with larger penile size to begin with, macrophallus, and then decreased size, and then hypogonadotropic hypogonadism. If you remember that boy who comes to us, his testes are extremely small. Even for prepubertal perspective, they look much smaller. So it means that he may probably be heading towards a hypo subsequently from that perspective, but they will not cause DSD. DSD will happen if you have a DAX1 overexpression because it's known as an anti-testis gene basically. So deletion will cause even better. There will be no problem to begin with in the initial phase, but then the LHFSH will be defective. So this NR5A1 and DAX1, as Dr. Alapan has mentioned, they are antagonistic to each other and their defects cause combined adrenotesticular defect from that perspective along with WNT4. Now further adrenal growth happens via multiple growth factors and a very important gene, the pro-opiomelanocortin or POMC. Now we will talk about POMC later, and we always think of POMC as basically something which is there in the pituitary, but it is also playing a role in the adrenal growth. So if you have somebody who has a pituitary problem, Dr. Sandeep, what will happen to the adrenal size at birth? Suppose there is no production of POMC, what will happen to the adrenal size? Will adrenal be formed or not? Number one.
Adrenals will be there, sir.
But
small.
Like if you don't have a TSH, thyroid will be formed, but thyroid will be small. If you have no FSH, ovary will be formed, but it will be small. If you have no LH, you will have some testicular development, but subsequent development will not happen. So this primordium will be formed, but from there, the POMC part, the growth will not happen. So they will basically present to you as a small adrenal and you may call it adrenal hypoplasia congenita. So when you say AHC, it's not just DAX1, it's a bunch of conditions which can cause adrenal hypoplasia, which I'll talk much more in when we're talking about adrenal insufficiency from that regard. From here, you need POMC. Of course, ACTH is part of POMC. So you need this POMC continuously. So if somebody has a long-standing ACTH deficiency, you will also have a adrenal atrophy, which is going to happen. So we often use, Dr. Nimisha, in diagnosing somebody with adrenal insufficiency, what is known as a ACTH stimulation test. So what is the concept? What do you think logically if you want to give ACTH? Who should respond if you compare primary versus secondary? If suppose adrenal is not there, will it respond?
No, sir.
Suppose ACTH is not there, should they respond?
No.
Why? They should respond, but they do not respond. Why? That's what I'm asking now. So of course you say, okay, ACTH is not there, I'm giving ACTH from outside, you should respond. Suppose there is a tree which is there, it's a small, not tree, like a small plant that you have in your house. You are not watering it. So because of the water deficiency, the plant has wilted. Now, if you give water now, will it start responding? So if you have a long-standing ACTH deficiency, the adrenals have shrunk, so they will not respond. What this means is that if you have a short-term deficiency, suppose you had a surgery recently, suppose somebody had an apoplexy, there may still be the adrenals which may respond. That's why we talk about ACTH stimulation test in two perspectives, low dose and high dose. Dr. Vibha, when you use low dose versus high dose, which one will have more sensitivity?
When we use the low dose, then the acute conditions of the secondary adrenal insufficiency will respond because they have some tonic stimulation from ACTH to the adrenals.
Yeah.
But when there is prolonged condition, then definitely we have to use the standard of 250 micrograms.
Yes. So in recent onset ACTH deficiency, a standard dose may falsely label somebody as normal. So if you reduce the dose, you will increase the sensitivity. So that's why we talk about low dose dexamethasone suppression test. The classical indications are recent onset ACTH deficiency and illness. So in some sort of a illness also you can have a similar scenario. Critical illness, that's a classical example from that regard. Now I've talked about three organs, of course, the kidney, the gonads and the adrenals. So of course, adrenals are the topmost and this is the urogenital ridge. Kidneys are of course in the lower side. We know that they have to ascend up. Now what happens is that you will have development, adrenal will stay pretty much there, the kidneys will go up and you will have the descent of the gonads and this is how the final position happens and adrenals are there in the superior anterior part of the kidneys, which is their location. Now the blood supply of adrenals also is very important and we need to understand that it is getting derivation from the inferior vena cava. What is the characteristic importance in terms of the blood supply of adrenals in terms of venous supply? Anything unique?
Sir, the left-sided adrenal is supplied by the renal vein, while the right-sided was directly from the IVC.
Yes, so if you can see here that from this side, the inferior vena cava is basically supplying directly to the right side, while to the left side, it is actually coming not from directly from the vena cava, it's coming from the kidneys. What is the implication of this?
It can cause any thrombosis that could affect the left-sided adrenals.
So if you have a renal vein thrombosis, what is going to happen?
It will only affect the left-sided. But
Yeah, so it may spread also, but typically if you talk about RVT, what will happen to the adrenal?
RVT, what will happen?
To the adrenal. You may have adrenal hemorrhage, so that blood will accumulate on that. So RVT often can cause adrenal hemorrhage. And one major differential is you have a child who was sick, he was in the ICU, suddenly has shock. Hyponatremia, hyperkalemia, there is a flank mass. Then there are two differentials, RVT versus a scenario of adrenal hemorrhage. So how do you distinguish between the two? And you will have hematuria in both. type of hematuria will tell you whether this is
So
more likely to.
microscopic versus macroscopic.
Yes,
will be
so-
there. So in RVT, there will be macroscopic hematuria, while
So
the
gross
hepatitis
hematuria will be there in renal vein thrombosis, while adrenal hemorrhage will only have microscopic hematuria. So that anatomy becomes important. This is a point which Dr. Sandeep has already mentioned, that the blood supply in the adrenal is from the periphery to the center. So all the blood from the capsule. So there is no direct supply to the medulla. It's coming from you supply the cortical capsule, and from there the blood goes inside, and from there it is going to take the cortisol along with that. So when you have a stress response, you will not only increase the production of cortisol, you will also increase the vascularity. And that is why the cortisol will go into side, and here it is going to produce epinephrine, which is then going to start acting. So cortisol response is essential to achieve a good epinephrine response from that perspective.